interested to get this through. To learn about palliative care, to deliver palliative care at their own levels, and bring in the holistic aspect of care that was missing quite since a long time in the world, and in our disciplines also. So I'll just try to share my screen. Okay, so it says the host has disabled.
Ma'am, can you try it now?
Yes, okay. Okay. So is my screen visible to everyone?
Yes, I'm good to go.
Okay. So we, as I said, we will discuss about palliative care delivery and the interdisciplinary team. But having said this, I would strongly recommend you to please go through the latest research papers and the qualitative studies that are available in the internet, in Google Scholar, in any journal that you come across, and learn more about it. So I want to tell you about the team, through which palliative care is delivered. Now, why I'm stressing on the team is because of the fact that palliative care always is a team approach. It cannot be the work of one person. Well, if you are alone, if the doctor is alone, if the nurse is alone, you can't do anything about it. But then that is also a kind of a solo practitioner model, and that has also been, given a lot of importance, because there is a dearth of palliative care professionals. There is a dearth of, good nurses coming into palliative care. There's a dearth of a lot of social workers working for terminally ill patients, for palliative care. So the solo practitioner model is also considered a team. So what is a team? It is a small number of people with complementary skills who are committed to a common purpose that is most very important. They have set their performance goals and the approach for which they hold themselves mutually accountable. So the underlying point here is mutually accountable. So the approach for which they have come together to form a team, and the goals and the paths to perform or meet that goal, those goals, everything that they do in that particular work, they are mutually accountable for their own actions. Now here, something very important that we should know is about the interdisciplinary team. So what happens in an interdisciplinary team is that there is a collection of identified members who have, who share a common team goal, and they work independently in planning, problem solving, decision making, and implementing and evaluating team related tasks. So the interdisciplinary team is essentially, a collective of professionals or people who have different expertise in different areas of life, but and they work independently in planning, problem solving, and decision making for reaching one common goal which is there for them. And in that process, they also implement and evaluate the team related tasks. So interdisciplinary team is a very important word in palliative care, because in a palliative care team, the team generally comprises of people who complement each other's work. For example, the doctor is not able to do everything, or not an expert to do many things, where the nurse actually comes in and plays her role in delivering that particular care to the patient. Similarly, the role of a social worker, the role of a spiritual person, or a chaplain, or a pundit, or a person like a physiotherapist, a music therapist, somebody who works with art and culture. All these people, they come together to form an interdisciplinary team in palliative care to deliver that particular care, which is tailor-made for the patient, tailor-made for that particular person. So these are the objectives of an interdisciplinary team, which are, you all will agree that there has to be an accurate and speedy assessment of this particular patient in question. The care must be effective and the treatment must be integrated. There has to be an efficient communication with the patient and the family, and also, with other professionals who may have a role in taking care of this patient. Maybe the institutions, for example, if there is a patient who needs, indoor care, and there's nothing just for that particular service, then maybe somebody from the team, especially, this task has been given to a social worker. So she or he goes to the institution, bargains about the care of this particular person and gets him or her admitted for an acute care or symptom management, or any kind of intervention that might be required. And last but not the least, there has to be an effective communication within the team members also. And if that fails, many things may not happen. And of course, the activities and the outcomes of this particular team in question must be audited. If you do not audit it, you will never come to know your shortfalls, your shortcomings. You will never be able to improve on your work. So these are the objectives of any interdisciplinary team. So coming to, the stages of team development, it's a very interesting slide that, I always love to talk about, because, every individual is an individual in himself or herself first, and then, belong to a certain clan, and perhaps when that person or that individual finds himself or herself inside a team where there are other professionals, people from other walks of life, they find it a little hard or difficult to manage themselves, conduct themselves. They have, find a place in that particular team so that, they are able to contribute to the goal of the team. So how do a team develop? How do they perform? So as you can see on the y-axis, there is this team effectiveness, and on the x-axis, which is the horizontal axis, this is the time. So the team effectiveness and time, you can see there are certain stages through which the team formation occurs, and that actually reflects the effectiveness of the team throughout the time that has been taken for this particular team to form and perform. So the first stage is called forming, which is coming together of all the team members, either by virtue of the leadership who has actually perhaps designed the care process, or the the duties assigned to each and every individual, and mandated to work in a team. That is called the coming together of professionals or coming together of team members. And that's a stage of forming. Slowly, when time passes off, uh, they start experiencing conflict among each other. And that is because of the fact that everybody wants to give their best in this particular team. And the ultimate intention and goal of each member of the team, each new member of the team, is to give the best care to this particular patient. And they want to do it their own way, because perhaps they don't know what the other person is capable of, or they are still not on the stage of appreciating the other person. So this particular stage is called storming, or there'll be storms, there'll be conflicts, there'll be disagreements, there'll be talking about each other, trying to make friends with somebody, and then talking about that particular person. It becomes a stormy situation in the team, and almost everybody in the team feels that, oh my God, I'm in the wrong place for all the wrong reasons. I'm actually losing my valuable time in doing nothing. And hence, you can see the effectiveness of the team is totally down at this particular stage. But then, the stage passes off, and there are situations where each and every person starts realizing their own responsibility. They start realizing their own a kind of contribution that they should be making for the team to work. And the ultimate goal, when they start realizing, is just giving the best for patient care. That particular situation or that particular stage is known as norming, and everything starts slowly normalizing for everybody in the team. There are situations which may actually uncover the norming phase. For example, say there is this home care team, and they're in the stage of storming, and they're not really wanting to do anything. And all of a sudden, they're told that they have to go for this home care of this patient with a very bad wound on the face, which is with a drooling saliva, with a lot of foul smell, perhaps a little bit of bleeding also. And this patient is in the last stage of his life. So, the team is being sent there, and then the doctor takes up his own responsibility or her own responsibility of giving the best possible medication for this patient to get relief of the pain, they get relief of the secretions that are coming out. And at the same time, very automatically and very surprisingly, the nurse also takes up the her role of dressing the wound, and takes directions from the doctor, the person that perhaps in the storming phase she was just hating, that I'm working with the worst doctor in the world. She also takes up this role of delivering the best to this patient. And the social worker who's present there, who's also the part of the team, he or she realizes that, oh yes, I have to help the family out, because of the kind of situation that has suddenly gloomed upon this poor family. I need to play my role. And after the task is completed, when they're back home or back to the office or their workplace, each one starts appreciating the effort of the other. And this is the start of the norming phase of a team. And you can see the performance of the team per se. It starts gradually increasing, goes up to a peak where they start working effectively, efficiently, flawlessly, and they bond together between each other. And this particular stage is called forming. I'm not going to the stage of adjourning because that's a little bit of managerial term, but what we need to understand is that formation of a team up to performance, the effective performance, efficient performance of a team goes essentially, definitely goes through these these four stages. Because of the fact that we are human beings, we need to give time to ourselves, and the team is a small baby that needs to be developed into a mature individual. And when it is an individual, a mature individual, that individual will perform to the best of the ability. So whenever you start off with your interdisciplinary teams back home, my advice is that you should always give time for your team to develop, your team to go through all these stages. Let them quarrel, disagree, conflict with each other. Let them come to a settlement where they agree to disagree, and then they will be in the best performing states. So this is about the stages of team development. So what are the characteristics of effective teamwork? So as you can see, on the left hand side, there's something called the organizational structure, which is very, very important because we work in an organization, whether small or large. The organization per se has a clear purpose, and that purpose is definitely the best patient care. The organization develops in itself an appropriate culture of honesty, of delivering the best possible care, helping people in and around, starting with specified tasks. They have distinct roles for different people, and every role, every person is important for the organization to run. There is a suitable leadership, and there are relevant members of this organization. And last but not the least, the organization tries to acquire adequate resources for everything to fall in place and take a path of success. The best example I can think of is definitely Palliative India, because it has a wonderful organization structure. The purpose is clear. They have a lovely culture of, complementing each other, developing every individual, every professional. They have distinct roles. The leadership is par excellence, and the members, their resources, everything is in order. So for an effective teamwork to take place, the organizational structure has to be very nice, very good, up to date. Secondly, the individual contributions definitely matter. The knowledge of each and every person in the team is very important, has to be updated all the time. The interests of gaining knowledge in their own expertise. For example, if the person is it's a social worker, then he or she has to update his or her knowledge in their respective fields. It's very important. It cannot be just taking an MSc degree or taking some degree and then having a laid back attitude that yes, I have completed this, now I'm working. That is not done. So you need to have a knowledge. You must have a feeling of constant competition with yourself, not with others, but with yourself, to improve yourself. And at the same time, you must build trust within your team members, with the organization, with the other processes that are already going on for that purpose. You must be committed. You must be flexible. Flexibility is the key to effective teamwork. You know, if today I am a doctor and I am placed with a team, and I can see that the patient requires more of nursing care than the doctor's care, I must step back. It's not that, oh, I am the doctor, so I have to do everything. The nurse will actually, take my orders and do it. It's not like that. I have to be flexible enough to give my partner, my nursing personnel, the space to perform, the space to work. So this individual contribution also, determines a lot of effective teamwork in itself. And then the processes, has to be coordination, communication. There has to be a lot of cohesiveness. When I talk about cohesiveness, the bonding between team members must be excellent, because if you cannot support your team member, in professional as well as in personal work. For example, somebody in your team has lost somebody at home, and all of a sudden that person has to take a leave, and the work of that person was such that you are unable to spare that person for a day. You must take that role of this particular person, so that this person gets that little time to take care of their personal, his or her personal work. So that is what I call cohesiveness in team process. At the same time, there must be somebody who's taking decisions, and that decision making is also a team process. Has to be the decision has to be a mandate from everyone in the team. It is, and even when there is something that bothers one person in the team, the decision must be reverted. The decision must actually go on taking the shape of the complete decision on the part of the team. It cannot be an individual decision making. Managing conflicts again, is important, because we do have a performing team as of now, but then we again, we have a tendency to disagree on certain points, but then those things should not bring about conflicts in the team members. Conflict is anyway an unhealthy thing, and that should be actually, it should not be there. So even when there are conflicts, the management of conflicts must be a priority. There are social responsibilities, social relationships, and then a lot of performance feedback. Yes. Rajlakshmi, give me just 1 minute, please.
Sure, ma'am.
So now we come to the important thing, the important topic of the palliative care team. As I said earlier, teamwork is an inherent feature of palliative care. And essentially, the interdisciplinary team is the unit of the whole teamwork for palliative care, with its own characteristics and challenges that it faces, from day-to-day activities to performing to giving the patient the best of care that should be given. So it should be both the palliative care interdisciplinary team should be both a defined team and must also be flexible. When I say defined, it means that the disciplines must be defined. For example, there has to be a doctor, there has to be a nurse. If possible, there must be a counselor in the team also. But when it comes to something called flexible, what I mean to say is that if the nurse is not present, perhaps the social worker can take the role of the nurse. He or she may not be able to perform 100% like a nurse, but then, the nursing issues must be known to this particular person. So, uh, the doctor must know the nursing issues. The doctor must appreciate the work of the social worker. The social worker must also realize the importance of the nurse and the doctor. And in absence of one or the other team member at any point of time, the complementary work must be taken over by the other people who are present in that particular team. So there is a core team always in an interdisciplinary team, and that core team is, the essential members are the physician and the nurse. This is because of the fact that we are delivering clinical care to our patients, and clinical care is at the core of any kind of palliative care. It is not necessary that the clinical care can only be delivered by the physician or the nurse individually, but it can happen that this particular team is a nurse-led team where the doctor may not be constantly present. Nowadays, in my own practice also, my nurses actually go for home care, and whenever there is a task which needs to be done only by the doctor, I generally make a subsequent visit for this particular patient, or else I depend on a lot on virtual communications, virtual meetings with the family and the patient, where whenever my nurses are on the home visits. So having said this, the social worker, chaplain, or the pastoral worker, or any kind of therapist, for example, the physiotherapist, they are also included. And that definitely depends on their availability and kind of adequate resource. And when I say adequate resource, the remuneration of these important people are also a question, where you generally put up where you generally think, or have to rethink on taking them as your team members, of course, because of certain resources that you don't have. Now, there is an extended team also when we talk about the palliative care team, and those are psychologists, physiotherapists, occupational therapists. There are dietitian and nutritionists, the specialist palliative care supports, which are from the oncology department, the neurologist, the neurosurgeons, the respiratory medical specialists, the cardiac people, the specialists from nephrology, etc., etc., etc. So the extended team can actually go on and on, where the interdisciplinary palliative care team is being supported by all these disciplines. So the question is, are the patient and the family team members for the palliative care team? The answer is yes, because palliative medicine itself is always patient-centered. The patient is at the core of everything, because this patient teaches us how to do his or her care. Without the patient, we will not be able to devise the care, right? So all the treatments must be given with the patient on and in accordance with his or her wishes. That is very, very important. That is where we call that palliative care or palliative medicine is a patient-centered medicine or patient-centered specialty. The patient must be considered part of the team. So whatever happens, the patient has to give us a yes or a no for any kind of intervention. May it be a small operation, may it be chemotherapy, may it be changing places, may it be deciding on the place where he wishes to die. So all these things need to have the consent of the patient. And then family members, they have an important role in overall care of the patient. That is very, very important. Sometimes when nobody is there at home, the family, the interdisciplinary team generally teaches at least a volunteer who is there in and around that particular patient to take care of that patient on a day-to-day basis. And hence the opinion of family members should be included while formulating the plan of treatment and care. So these are very important points for all of us to know, because as a tradition, you must have experienced this also, that traditionally in hospitals, in nursing homes, in clinics, the family members and the patient are hardly included in the care process that is being devised. It is something that is written strategically and placed on the patient or the family members' tables, and they never call for a discussion whether they'll be able to do it or not. A small example that I can give you is writing very expensive protein powders, or trying to give albumin infusions, which seldom find any kind of evidence in the papers. So those things are being followed, those things are being given. The doctor or the nurse never asks, will you be able to buy this? Will you be able to afford it? They will just write it and they'll give you, this is good for you, you have to take it. And then the patient and the family, suffers psychologically. They curse themselves for being poor. They curse themselves for being not able to take care of their patient by buying this simple protein powder, advised by the doctor. So that is the reason why the family and the patient must always be included in any kind of decision. May it be a small, protein powder which is being advised for the patient. You never know, you might actually come up with better ideas of how to improve the nutrition of this patient. Okay. So the members of an interdisciplinary team, you can go on adding to this list. This is a small thing that I have tried to include, and everybody will have one or the other, virtue, because of which they are inside the interdisciplinary team. So it can be a chaplain or a pastoral worker. It can be an occupational therapist. The chaplain is important because, because of our, belief, the belief system that we are in. Christians will have a different belief system. Hindus will have a different belief system. The Muslims will have different. The Sikhs will have different. So everything will be different. We all stay inside our own belief systems, and we are comfortable with people who have the same belief system as ours. So that is an important fact that we need to address, because we just can't ask a Hindu person to go into a mosque and pray because the doctor is a Muslim. So, I'm not actually really trying to hurt anyone's sentiments here, but I'm trying to lay out a proper plan where, we can help our patients who are inside their own belief system, try to get answers for their questions, for their spiritual questions. Why me? Why has this happened to me? And has my God punished me because of so many things? So all these things would actually be answered or addressed by somebody who follows the same belief system. So that is why maybe a chaplain or a pastoral worker, or even somebody who's just a spiritual person, just believes in a supreme power that is actually ruling us, ruling the human beings. Coming to the occupational therapist, very important, because we find these kind of therapies being given to elderly people, maybe the geriatric population, I mean, and also they find a lot of importance in palliative care also. By and large, music therapy has been included very recently in palliative care in India. This has been rampant in the West, definitely. You also find art therapy also, wherein you ask small kids who are terminally ill to, express their thoughts through art. There are people, they are professionals who can actually bring in that particular sentiment out of a child through art. So psychologists and art therapists work hand in hand together to find out what is going on inside a child's mind, who's terminally ill, definitely terminally ill. Because children per se are unable to verbalize their thoughts. They cannot actually bring out in words what they're thinking about. They want to say something, they land up saying something. So through art, through music, and perhaps through exercises also, through dance therapy also, children can, it's a fact that children are able to give their thoughts a kind of a visual appearance or a form where we as adults are able to understand the innermost feelings that they are going through. Physiotherapist, I will not go into details about physiotherapy because you all know what physiotherapists are, what kind of importance they have. But the point here to note is that we generally must have each and every discipline, each and every person in this particular discipline to be trained in palliative care, because the principles of palliative care, the practice of palliative care is a little bit different than the traditional medical interventional people or the specialists, because of the fact that we need to unlearn many things that we used to learn while we were learning medicine, or we were learning nursing, or being a physiotherapy student or a music therapist. We need to unlearn many things and learn more about palliative care relevant facts, and how physiotherapy or my own discipline will be able to contribute to the care of this particular patient. Dietitian and nutritionist is a very good example, because especially for cancer patients, for patients who cannot eat, are terminal, are dying patients, the nutritionist or the dietitian just cannot lay out a long list of food, or a long list of certain items that are going to be, because they're not in a position to eat. It is the process that is actually taking the toll on their diet, on their body, because of which the patient is unable to eat. Unless and until the dietitian or the nutritionist understands this fact, he or she will go on hammering the patient that you do not eat, you have to eat. The patient cannot eat. We need to understand that the patient is not able to eat. So what do we do at that point of time? So all these things need some bit of training, some bit of exercise with palliative care people. So that is why education in palliative care is important for every member that forms the interdisciplinary palliative care team. Coming to the settings where we can deliver palliative care, I would deliver palliative care in any kind of setting. If the patient needs my expertise, I can deliver it right at the home of the patient. I can also make a small outpatient facility where the patient, if he or she is able to come walking to me, I can see him in my clinic. My nurse can actually administer her nursing expertise for that patient at that point of time. My counselor or a social worker can actually intervene for that particular patient. But having said this, if the patient is not able to come, is at home, and I am also not able to visit that patient for that particular day, the family member is most welcome to come to the outpatient facility and work out a plan with us. At the same time, there are a lot of daycare centers who generally bring in people who are at home because their treatment options have been exhausted, and they are now sent for best supportive care at home. They may not be imminently dying, but they're absolutely in the terminal stage. They are able to eat a little, they are able to interact a little, maybe for some reason the hemoglobin of that patient has gone down, and we need to give him some kind of blood transfusion to this patient. We transfer that patient to this daycare center, we give him a pint of blood, and then the patient happily goes out of the daycare center back home. So all these things can happen in a daycare center, and that is also a part of palliative care delivery. There are ICU setups, which are known as acute care facilities. And many people in the ICU, may or may not be in the terminal stage, but then require some kind of pain and symptom management. The family of that particular patient who's inside the ICU are not able to see their patient from inside, but they're all the time waiting outside of the ICU and waiting for their patient to get well and come home. But that particular period of time, a social worker or a counselor, and even the nurse who's working in the ICU can be, very good support for this particular family. So acute care facility palliative care delivery is also nowadays very, very important, and this is being realized by many hospitals and many institutions. We have specialized palliative care units, which generally, are concentrated on delivering specialist palliative care, and then the hospice. Just coming to this one by one, but before that, I would like to tell you about something about the home care teams. So they provide specialist advice. When I say specialist advice, it is specialist palliative care advice, and they work alongside the community personnel. For example, there are volunteers in the community who are rendering voluntary services to these people, to the patients who are in that particular area. And now the home care teams actually come over to give their advice. They are making weekly or bi-weekly visits to these patients, and the community people, the community volunteer generally will organize everything for these specialist home care teams to give their care. Secondly, the community personnel, they may be volunteers, they may be social workers, they may also be, physiotherapists working in that particular. And then there are general practitioners, the family physicians that we have. They are excellent caregivers. They're excellent community volunteers for us, because many times the specialist palliative care unit generally depends on the family physicians to provide a remote care to these patients, and I have had this personal experience of working with many general practitioners, because uh, there's absolutely no ego issues with them, as people might think, but they are so eager to provide that particular relief to to the patients, that they just go out of the way. They make night visits. They coordinate the care. They call me up whenever they want. I have had this experience, and believe me, it is truly satisfying. So whenever you have this chance of getting somebody, a general physician in your locality, please do approach that doctor for a support, and you believe me, you will never be disappointed with what they do. And the last but not the least, the community workers, they generally coordinate the care of patients, forming a bridge between the specialist palliative care team and the home care team. So this is the importance of home care teams, because they would be the bridge, they would be the connecting link between the specialist palliative care services and people in the community. Just to let you know some advantages and disadvantages of performing home-based palliative care. There are studies that have indicated that more than 70% of people prefer to die at home, and henceforth home care becomes an important integral part of our care. There is more autonomy for the patient. There is privacy for the patient. Freedom is at large for this patient. And interestingly, they feel very safe at home. The family can anticipate the loss. If the patient is dying, they can anticipate the loss. They have a better bereavement period because they already know that yes, my father or my mother or my brother is going, and I have to accept. So they accept death as a normal process of life. At the same time, definitely there is a reduction of cost. They prevent unnecessary hospitalizations. So these are the advantages of having home-based palliative care. But then it comes with their own share of disadvantages. The care may be difficult or impossible if it is against the patient's wish, because many times the patient might say, oh my God, you're not taking me to the hospital. I just can't bear it. You have to take me to the hospital. So that's a disadvantage. Even if you want the patient to be at home, it becomes difficult. Or the patient, is living alone, far off from the hospital. The patient has nobody to look after, there's no family member. The children are out of India or they are not there. The patient is unmarried. She's alone or he is alone. So these type of patients, that's a disadvantage for home-based care. And definitely, suppose there's a patient who has a lot of symptom burden. has been having a lot of symptoms which are uncontrolled and will need a higher skilled skilled care for taking care of these symptoms. And those patients can not be given any kind of home care. The family is physically or emotionally tired. The woman at the end of the day is the one who's always looking after the children. She's cooking also, she's looking after the patient also. The male members of the family are going out for their work, so everything comes upon this particular lady of the house, and she is unable to meet with the minimal comfort needs for this patient. And then the burden of care shifts to the caregiver from the team. So home care has its advantages and disadvantages also. That is the reason why we generally keep the patient in a 360-degree of care, which I generally call it as a continuum of care, because the patient comes to me in the OPD, I see him in the OPD, the patient goes back home, and if the patient is not able to come back to me, I coordinate with the home care team and give my advice for that particular patient to be taken care at home. And then at some instance when the patient is not stable, or patient requires a blood transfusion, or the patient is having an intense amount of pain which is not being controlled by the medications that already have been given, those patients I would like to bring them to the inpatient care, perhaps to the daycare facility or the hospital, to give that care, manage her symptoms and send them back to home. So that is a kind of a 360-degree care for patients. You can see these home care pictures actually. That's a dying patient on the right side. These are actually real pictures of real patients. Similarly, the outpatient facility will also have its own share of advantages and its disadvantages. Patients can have a consultation from a multidisciplinary team. There can be family meetings, counseling, support group activities. These can happen in the same place in the outpatient facility. And in case of a severely symptomatic patient, a daycare symptom control can be easily arranged in that particular facility. But then patients may have to wait a long time, on long queues in the OPDs. If any of you have visited Tata Medical Center in Mumbai, you will come to know what long queues are. There may be space issues because India anyway has always had space issues. So, a severely symptomatic patient may require a more comfortable space where, this outpatient facility may not have that. Consultants from all disciplines may not be available on the same day. So if I need, if there is a patient who is a renal failure patient and I want a consultation to be done from the renal specialist, from the nephrologist, he or she may not be available on that day. So the patient may have to come again to the patient facility once again. Daycare centers, the symptom control can be easily achieved by keeping the patient under close monitoring. They can go home after a short day course of medications or interventions. And these interventions can be blood transfusion, they can be fluid replacement, they can be IV morphine trial or whatever. But then they may not be cost effective for patients, because running a daycare center, as you can see in the picture, with world-class facilities, they may not be very cost effective for these patients. And the treating team may admit only those who are not in the end of life. Many times it is a mandate from the hospital administration that end of life patients must not be admitted to the daycare. or must not be admitted to the hospital itself. And that may actually frustrate the patient or the relatives. Coming to the acute care facility units, generally the semi and unconscious patients are in the intensive care units. Patients with COPD and ILDs, some neurosurgical patients, patient in the cardiac care units. These are the patient population we can provide palliative care to. And palliative care is provided as an adjunct to the main facility. This is a specialist palliative care unit. This is one of our patients, and he was in extreme pain when he came, because of which we had to admit him. And then we did the IV morphine trial, and you can see the patient is actually quite alert and has sat very properly on his bed. He's smiling. So this is the beauty of a specialist palliative care unit, where you can perform to your satisfaction and to the satisfaction of these patients' care. All members in a specialist palliative care unit are specialized in palliative care, whether that person is a chaplain or a social worker or a counselor or a nurse or a doctor. They function especially as an inpatient stabilization unit and mostly manage uncontrolled symptoms at the end of life. You all know about hospice. Hospices generally ensure the best quality of life and the best quality of death for any kind of patient. Okay, they generally take patients with a minimum prognosis of 6 months, and then intensive acute care is not provided to these patients. Okay, of course, we do provide pain management and symptom control, but not other acute care things that are being done in a specialized palliative unit. So we have Shanti Avedna Hospice in Mumbai and Delhi. In Assam, there is a one called the Sacred Heart Palliative Care Center. And you all must be knowing about Karunashraya Hospice in Bangalore also. So there are other hospices being built in and around India as of now. And this particular concept is really becoming very popular. So I come to a very important part of palliative care, which I think everybody should know, because in one way or the other, we are actually into social work. Whether the social worker is specifically trained in social work, or that person is a volunteer, or that person is a counselor, or even a doctor or a nurse, or from any other field of life. So social work is very important in palliative care. So there are three forces that generally shape the social work role, and those are: number one, the non-medical social goals; secondly, the teamwork and the multi-professional skills that are required to meet the non-medical goals; and expectations of patients, carers, relatives, friends, and various palliative care professionals, including social workers. So these are the three forces that generally shape the social work role. So expression of emotional pain, the need for exploration of spiritual pain, and the need for practical help. These are the three non-medical social goals that are recognized. Okay, so we need to understand how emotional pain is expressed. We need to understand why we need to explore spiritual pain, and why we need to develop practical help for these two things in a person's life. And when we talk about emotional and spiritual pain, it is not only the patient, it can be anybody from the interdisciplinary team also. Okay, so it's a huge subject per se, and you need to plunge, dive deeper into every aspect of emotional and spiritual pain. So, what are the perspectives of the social worker when it comes to the social role? Number one, what they cannot do. That is more important, because, as a social worker, people would, oh, you are a social worker, so you can bring me a lot of funds for my patient to undergo this particular treatment. No. So this person, the social worker, is under a lot of burden. So the perspective of this particular worker is that I need to understand what I cannot do. I cannot cure pain. I am unable to dress bad wounds. I cannot offer appropriate religious rituals for these patients. So there can be other aspects also in this particular, in this particular step. But the point is, the person who is a social worker must identify, must understand what are the limitations of this person, what this person is not able to offer to these patients. When this definition, when he defines his limitations to himself, he finds ways and means of, helping the patient and the family in a very different way. Secondly, it is important that the social worker sees the patient as part of the family and the social network also. So he cannot actually, take out the patient as an individual and work towards it. The social worker needs to understand that the patient is also a family member of a family, and this family and the patient belongs to this particular community and social network. Okay. And thirdly, he needs to understand the implications of special situations for the patient. For example, the mental health legislation that applies to India, to patients in India. For example, if the patient tomorrow decides on, euthanasia, and he asks that I need to die, I don't want to live my life, this particular aspect must be answered by the social worker, must be addressed. Why? By the social worker. He must know, what are the legislations, what are the laws that govern end of life, that govern, mental health issues, and things like euthanasia and, all these laws. So he must be educated on these particular aspects also. So the main areas of social work are always in these four spheres. He needs to assess. There must be good interventions that are to be designed for the patient care. Very importantly, bereavement care is also important. And then a wider role that the social worker sees himself. So emotional, social, practical, and financial assessment of the patient and the family is also very important when we assess them. The main goals are identify any need for future assessment, coordination between disciplines. For example, the patient actually needs some kind of financial help from a bank, okay, and he doesn't have the adequate papers, but then those papers can be taken out. So the social worker is the link who actually goes on to that extent to find out those adequate papers needed for this particular patient in order to take that financial help. Okay. In Assam, there are two things. The Ayushman Bharat and the Atal Amrit Abhiyan. These are the two cards that give financial help for cancer patients, financial help for terminally ill patients. Now, the social worker is the person who actually brings out the packages that are designed by the Ministry of Health for these kind of patients. And unless and until the social worker is determining through his or her assessment about the requirement of the package, this may not be very effective for the person, for the patient to actually take the advantage of these two cards. I'm just giving an example, the local example of my state, what happens, how the social worker helps. Okay. Practical assessment, maybe the need for specialist help. For example, the patient has been having intense pain and the home care team is not able to, find out ways and means of helping this person. The social worker can actually approach a specialist palliative care service, which may not be directly linked with the home care teams, to come and advise the home care team over virtual platforms, or call them for a meeting and then discuss on the practical issues. The assessments for these patients by the social worker can be at individual, family levels, and assessing for physical resources as well as social resources. So interventions are aimed at patients and families in need of help to cope with their situations. Firstly, adequate and appropriate information to patients and their family members. They have to facilitate proper communication to reach a solution. They must imbibe the confidence to act on certain situations, okay? And then facilitate required resources, as I spoke about the Atal Amrit Abhiyan card and the Ayushman Bharat card. Similarly, there are certain facilities that has been given by the government but are not known to people, especially uneducated people, uneducated families. And the social worker is the one who generally facilitates these resources. And then, of course, last but not the least, the bereavement support. And bereavement support can be a one-to-one bereavement support. He or she may facilitate the meeting of the person, the bereaved person, with a specialized psychologist for certain help. There can be, bereavement groups when needed. For example, this is very rampant in the West, the bereavement groups, because of their social, structure. The bereaved family members, whether one or two, they actually come on a common platform and share their own grief. Bereavement counseling is a very vast specialty of social work. Extended grief counseling in a similar way, and then taking care of the special needs. For example, the loss of a child, the loss of a young adult, the loss of a young spouse. So all these things, all these grief, all these bereavement supports need to be very special, because of the intensity of the loss. So on a wider role, the social worker does an internal consultancy. For example, support the doctors and nurses to carry out the social work tasks, extending from simple advice to a leadership role in the interdisciplinary team. The social worker should also be involved in day-to-day decisions on management of patients because of the reasons that I've already talked about. There are certain examples where patients actually give suicide threats because of unmanaged sufferings, and those things are to be taken care by the social worker, or brought into the notice of the interdisciplinary team about these things, and then work with interpreters if needed. For example, in the lockdown period, there were a lot of people who have migrated from other states to a state where that particular language is not used. For example, there were Biharis and people from Uttar Pradesh who had gone to Kerala for some work, and they have language problems. And when they had this, the COVID situation was there, the social worker was responsible for interpreting the needs of these people to the authorities. And then community liaison, routine general contact with people, specific actions like creating a care package, facilitating community resources for the patients, children's education, job for a family member, awareness generation in the community. These things are very, very important for the roles of the social worker. Involving the family members in the care process, which we called as the end user involvement, because the user at the end of it are the ones who are going to give us the biggest feedback about our work. And then establishing long-term relationship with a bereaved family. And not only that, education and awareness generation in the community, educating people about social work, about palliative care, about specialized care for people. Those are also the wider roles of the social worker. So I'm coming to conclude the last slide of my presentation. Interestingly, the social work field in palliative care is actually a newly emerging one, although it has been there since a long time. But specific social work in palliative care is very new. The challenge is not only to demonstrate expertise in biopsychological assessment and intervention in advanced illness, but also there needs to develop a leadership role in development and research of new models of care and specific psychosocial interventions for patients and families. So this is about palliative care delivery models and interdisciplinary teams. This is very small, very less. I think I've just covered 30% or 40% of it. I would encourage you all to please go back and read more about this, because this is a huge, phenomenal change that has come on palliative care delivery. Okay, thank you so much for a patient hearing, and I'm ready to take on questions and will try to answer to the best of my ability. Thank you so much.
Thank you, Dr. Sanghamitra, for that excellent presentation. Whatever given to you, you have completely taken it fully. So thank you for that. So till now, we don't have any questions. So you can either unmute from your end and speak, or you can give your questions in the chat.
May I ask a question?
Sure, Manoj sir.
Yeah, so the question is that what is the cost? I'm out of Bombay. As I mentioned the last session, that I'm planning to set up a center, palliative care center in the outskirts of Mumbai. So the question is, we are looking at a hybrid model where it is charitable. It would be a combination of people who can afford to pay, and those who can't afford to pay. So I have two related questions. What are the average costs per, what one should be, so that we want to make it affordable per month? And secondly, related to that, in the neighboring city which is there, if there is home healthcare required, visit, what are the usual per visit charges? I know it will depend on city to city living index, but just a number.
So everything comes down to economics.
Yeah.
Right. So definitely, as you said, sir, it's very important to, chalk out a P&L for yourself, because that is what is very important when you think about establishing a home healthcare service with a palliative care approach. I sincerely cannot give you a proper range of how much it would cost, but if you are thinking on a simple model of one doctor, one nurse, and perhaps a social worker or a counselor in your team, along with perhaps an outpatient clinic, you need to find out the cost of taking patients on a radius of perhaps 10 to 12 kilometers from your center, adding up to the salary of a driver, the cost of the vehicle, what kind of amenities would you provide to the patient? And when you talk about affordable service, are you going to actually give these patients medications free of cost, or the consumables? When we speak about terminally ill cancer patients in my area, I get patients who are having a lot of issues with head and neck cancers, so they consume a lot of dressing materials. So those things need to be found out. Since I am in the northeastern part of India and you are in Mumbai, I will not be able to compare these two costs, but of course, it might be a little too costly when I think myself sitting in Guwahati and you are in Mumbai. So maybe, you'll have to perhaps chalk out a proper plan of how you want to deliver, what are your deliverables for that question. Do you want to extend 24 hours nursing service to a patient, or do you want to just go and give a kind of a visit plan to a patient, for example a weekly visit, or want to train the caregivers for the amount of time that you are not going to attend to these patients? So I think you need to chalk out all these things in a very proper, well maintained manner. Otherwise, you might end up in huge loss. That's my personal experience.
Thank you.
Good evening, ma'am. My name is Sofiana Babuji. Once I worked in a palliative center, as a student, it's one patient has said to me, she wants to work. She's paralyzed due to stroke, and not she can't speak that in a proper manner. She has language issues. Language issues means she can't talk. How can we help these type of patients when they cannot open up their needs, or they can't ventilate their problems? How can we help them?
So thank you, Sophia, for that very excellent question. I'm sure you are going to have communication skills as a very major part of your program. But having said this, I can definitely advise you to, take the importance of silence as one of your major tools in communicating with the patients. Let me tell you, at least 90% of our communications are non-verbal communications, right? If you have an experience with pets, dogs, we don't talk to our dogs or cats, we just pat them. We, our actions, the way we look, the way we, signal, those are the things that comes under the non-verbal communications. And when, if I have to think that this particular patient of yours, doesn't want to speak out, has so many things inside her mind, inside her heart that she is unable to verbalize, I would advise you to be with her for the time being. You need to sit with her. That particular presence is extremely therapeutic. It's not always that we need to speak and give all kind of, gyan, that you do this, you do that, why are you not eating? Why are you not going there? Why are you not speaking this? No, just sit there, listen to what she has to speak. Listen to the silence that is there, It will be very uncomfortable for you, I know that. But as you practice it, just be there. Just try to tell her, perhaps I can read you a book. All these actions are extremely therapeutic for that patient. All these actions are positive for that patient. And you will, at one point of time, will see that the patient slowly tries and opens up. It is like a kind of a floodgate that would open at one point of time, and she will keep on talking about everything that she's facing in life, and that is going to help her. My advice would be to maintain silence and not hammer the patient to talk about her suffering.
Okay, ma'am. Thank you.
Thank you. So, ma'am, we had a question from Ahmad regarding the learning materials, the books which could be read. So, we are going to share the Indian Primer of Palliative Care and a book introducing palliative care by Robert Tycross to all. Both can be read and learned. We have another question from Saloni, ma'am. Can I read it out? Okay. Is it necessary that a social worker is qualified with a degree or master, or any person who is willing to make a change and help others is considered to be a social worker and has a background with all this?
So this is a very dicey question. I believe that education is an important tool. I'll tell you an example why I'm saying this. So when I came into palliative care, I was, I had skipped my MD. So I was not interested in studying biochemistry. So I just stopped it in 1.5 years, and I got married. I came to Delhi. I was in the best of my days with my hubby and my son, and I thought that's the end of everything. And then after 4 years, when I started getting bored, when I started getting lonely because my son was in the school, my husband had gone to work, I had not much to do except for, cooking and cleaning the house. I realized that I need to work again. And when I started applying for jobs, that time I was not really, into palliative care. So when I started applying for my jobs, I realized that the degree that I had had a little, very little role to play in what I was trying to, give to that particular organization. And so I needed to develop myself. And interestingly, I got a job in Cancer Support, which is a very well-known international organization in Delhi. And, I am indebted to that particular organization because it introduced me to palliative care. And I started having this, debate in myself that whether I should take up palliative care as, my specialty or not. And then when I started practicing palliative care, I started to do, trainings. I started to go to conferences, and which we generally, for professionals, we call it the continued medical education. So the whole gist of my thing is that education for any person is important. If you do have a chance of getting a degree for yourself in any specialty, which is going to improve, not only improve your CV, but also improve the acumen that is needed for you to give this particular care, or excel in this particular field, I would definitely want you to go for a degree, a specific degree, because you will learn more, you will be able to deliberate more on that subject, and at the same time you'll have a control over your situation. So that is very important. So I would personally advise you to keep on learning, not only through Zoom meetings or something, but then if you have the resource, if you have the time to gain a degree, why not? You should always do that. Anything else?
Yes, thank you, ma'am. I hope, Saroni, you have got the answer.
I can see another question, I think.
Yes.
Ahmed Muntasir. I'm from Bangladesh. My country don't have any social infrastructure of palliative care. Palliative care is institution based here. Okay. How to involve social workers, community workers? Any suggestion? How did India build up social groups? Okay. So thank you, Montazir. It is a very important question. I think when you have put on this question, you have already started to plan out something for your country, for your locality. That is going to be, very good. I can actually advise you on starting with a small palliative care team. If you are a social, I don't know your background, but if you are into social work, perhaps you can, connect with people who are like-minded. First of all, try to talk to people who are like-minded. They have this particular this intensity of actually doing good for such kind of patients, and maybe you can actually come into a common platform, try to find out time to deliver such some kind of care. Maybe just talk to people who are suffering from cancer or any kind of terminal disease. You can actually specify some time for this particular aspect. For example, you go to a medical college where there are cancer patients in the college, admitted in the wards. You can talk to those caregivers, or talk to the family about how they are coping up with this particular problem, and that you will see will surely actually escalate your demand for such patients, because first day you talk to one patient, one family, next day there'll be two more coming in search of you. So this is how you actually build up a base for yourself, and then try to prioritize your resources. If you are a sole practitioner person, then maybe you can take the help of a nurse with the same acumen, try to get her into such kind of a training that you are having right now, and then find out a doctor who's able to help you, in one point or the other. That is one way. Secondly, you can actually, you've said that it is institution based in Bangladesh. So you can actually approach these institutions to give you some support to start off with, home-based care. Maybe extend, their expertise for patients who you have found out in the community. So that can be, and then you work out the logistics, the funding, and as the gentleman already said, fund is an important part. Funding is always an important part. You can actually, perhaps that would be a small step that you can take, and you can actually see this slowly growing in your area also.
Thank you, ma'am. We have another question too. Is there any courses for palliative care India by Dr. Tasneem? Care courses in India.
There are many palliative care courses. So are you talking specifically about social work or counseling, or I'm not sure. But if you say palliative care courses, there are courses for doctors, there are courses for nurses, there are courses for social workers. Pallium India has courses for social workers and volunteers, I'm sure. And I think Rajlakshmi will be able to help you with this particular thing. There are many courses, many organizations are running, but since I am more into Pallium India, so I would advise you to take up Pallium India course only.
Thank you, ma'am. So indeed, Dr. Tasneem, we can contact us. We will let you know about the courses we provide, and in general, what are the courses available in India also. So I think there are no pressing questions now, and we have crossed the time by 7 minutes. Extremely thank you, Dr. Sanghamitra, for joining us and giving a wonderful session today. So we have shared the feedback link. Give it a minute, do it, then only leave the meeting. We can see you next Wednesday with another talk. Thank you all.
Thank you, Rajlakshmi. Thank you, everyone. Thanks. It was very nice talking to